Starting recording. Hello, good evening, good afternoon, good morning, good day, wherever you are in the world, and welcome to the Black Belt Academy of Surgical Skills. My name is David Regan. I'm a retired cardiac surgeon and now a professor in the Medical Education Research and Development Unit at the University of Malaya in the Faculty of Medicine. We are coming to you live from Kuala Lumpur, and Ayushi in New Delhi is standing in for Dr. Aprajita this evening on production. And thank you to iEcho. We are reaching over 400 people in 21 countries and growing. Please pass the word around and encourage people to participate. I'm very excited to announce that we are launching face-to-face Black Belt Academy here in the Faculty of Medicine on the 29th of November, and 12 people have signed up to join this program. This is not a one-session skills, but it's a transformative program where we're going to take people through increasing belts over a period of 18 months in the hope that they too become black belt in surgical skills. That can only be done with practice. What we'll do is give them instruments and a syllabus and direct them on how to practice at home. And that's why we call it homing surgical skills. This evening, I wanted to go right back to our foundations and explain to you why martial arts and surgery and the philosophies with it, because we cannot separate the cognitive processes and the technical skills of surgery, nor can you do that in martial arts. You see, martial arts and surgery share an intrinsic blend of precision and artistic prowess. Now, Professor Zalea, who is the sensei, wrote this passage, and I've put it in the reading material. But I'm going to quote past it because it's a lovely introduction to what we're going to be doing this evening. You see, both require mastery of movement, control, and fluid execution. And it becomes an art. And a seasoned martial artist, as with a surgeon, moves with grace, seamlessly blending power, control, and precision with fluidity and finesse. And this is honed through many years of practice and repetition. So it becomes a natural way of practicing and a natural way of doing things, effortless. Furthermore, the martial artist needs to adapt their techniques to the situation based on the opponent's movements. Likewise, the surgeon must adapt their techniques to the situation, the pathology, and the patient in front of them. And this adaptability really reflects a deep understanding of the craft. And this is where science meets intuition and precision becomes an art. It was a lovely description, or is a lovely description, by Prof. Zalea, who's also a black belt in martial arts, as many of our senseis are. But there are a number of other aspects of mindset that I'd like to introduce you to. And I'm wearing my katana and hakama this evening because I want to emphasize the way of the samurai, or Bushido. What's interesting in Japan, there's a long history of surgeons and samurai families. Indeed, I understand that an Australian student was studying pediatric cardiac surgery under an eminent surgeon in Japan who had designed a new operation for congenital heart defects. But because he is a proud samurai, he preferred not to speak English at international conferences, and I understand this Australian trainee took it back to Australia and put his name to the operation. I'm not sure of the details, but there is that history and pride in being a samurai. There are 8 intrinsic codes for being a samurai, and I think they apply to service as well. The first is rectitude or justice. And a well-known samurai defines this as rectitude is the power to decide upon one's course of conduct in accordance with reason and without wavering. The second is courage. And indeed, in surgery, you do need courage. But courage is what's doing what is right. The third is benevolence or mercy. You wouldn't have fought it with a sword-wielding samurai. But affection for others, sympathy, pity are traits of benevolence and the highest attributes of the human soul. Confucius actually said that the highest requirement of the ruler of men is benevolence. I think benevolence should be there in surgeons. Politeness and courtesy is rooted in benevolence, and courtesy and good manners are well noted in Japanese culture. Indeed, think about when you go around, how many please and thank yous do you hear and see in your workplace? Likewise, do you hold the door open for people as they walk through? The next thing for a samurai is honesty and sincerity. And a true samurai disdained money, believing that men must grudge money, for riches hinder wisdom. Thus, the children of high-ranking samurai were raised to believe that taking money showed poor taste, and that the ignorance of the value of different coins showed good breeding. So Bushido, in the way of the samurai, encouraged thrift. Not for economical reasons as such, but for the exercise of abstinence. How that plays into private practice and surgery, I'm not so sure. But the next one is the sense of honor, a vivid consciousness of personal dignity and worth. The samurai was born and bred to value duties and privileges of his profession. And in many respects, I think a surgeon is or ought to value the duties and privileges of our profession. You see, fear of disgrace hung like a sword over the head of every samurai. And it's worse than the stain of falsehood and dishonor. Same for surgery. Loyalty. Loyalty to a superior was the most distinctive virtue in the feudal era in Japan. Personal fidelity existed even among all sorts of men, including gangs of pickpockets who swear allegiance to the leader. But only the code of chivalrous honor does loyalty assume paramount importance. Lastly, there's character and self-control, and this is most important for the surgeon. There's a difference between good and bad, and between right and wrong. They are givens, not arguments subject to discussion or justification. And a man should know the difference, and a surgeon should know the difference. And what's interesting, it was a samurai's obligation to teach his children the moral standards through the modeling his own behavior. And I look at that and think, well, we have a duty to role model those behaviors for our trainees for the same reason. But what about mindset? Now, the word shin, spelled S-H-I-N, translates as heart or spirit. And it's a term deeply rooted in Japanese philosophy and spirituality, and representing the innermost person. And in practicing the sword, on Sundays at the Japan Club, the concept of sheen is expressed all the time. This is often associated with emotions, intentions, and is the very core of one's being and of focus. The first is Shoshin. Shoshin is an empty mind, devoid of all preconceptions, donated by the white belt, and a willingness to learn. You see, some people reach black belt and think they know it all. Indeed, some people reach consultant level and think they know it all. But the black belt denotes Shodan, which literally means first level. The important thing is the beginner's mind is always aware of possibilities. So no matter what level or how skilled you are, please remember to maintain that beginner's mind. And although I'm in theory second dan with a sword from the United Kingdom, I come here to train in the Japan Club, and I feel I don't know anything because the level of training and attention to detail is far superior to what I've been exposed to date. It is profound, and being a student translates into how I approach teaching as well, as we'll cover later on. The next state is Mushin. Mushin means mind without mind. This doesn't mean your mind is empty and vacant. It simply means absence of ego, distractions, worries, or preoccupations. It's when your mind is completely free and present with full awareness of the self. And it's not something that you can practice, it's something that you need to experience. But it's exactly what athletes, sports scientists, and even surgeons refer to as getting in the zone and the flow state, and operating and dissecting and demonstrating skills to you on the models in the Black Belt Academy. I find myself entering that flow state as well. Ishin. Well, Ishin is in one mind. You have a clear understanding of yourself and your purpose, investing all your mental, physical, and emotional energy in that purpose. And that becomes a potent force that Ishin can bring down walls. When we talk of the quality of Ishin in a person, we mean that person does not have two faces. He is straightforward in his dealings with others. His words and actions stem from a strong feeling of oneness and a feeling of being. And such a person takes full responsibility, no matter what, as a consultant surgeon leading a team in theatre. He is a man of honor and shows respect to others, and when makes a mistake, always apologizes. Fudishin is another interesting one. Again, this is a state of imperturbability or unshaken mind, to remain calm, focused, even in extreme adversity, and remain clarity of thought and composure. Professor Samagliaku, I had the privilege of operating with him as a trainee. He said, David, cardiac surgeons don't jump. So Fudishin is especially important when the stakes are high, like operating. But you cannot leave any room for doubt or hesitation to creep in, because that can cause negative thoughts and spiral out of control. In fact, Fudishin is very good for goal setting. So if you set your mind to something, you don't allow anything to shake your belief in achieving it. So it's being steadfast. Lastly, and what is practiced and what is looked for when training with Iaido is Zanshin. Zanshin is maintaining that focus. Why? Because it ain't over until it's over. It's keeping that focus lingering after you finish to ensure that there are no other possible threats. It's a relaxed awareness. And as one boxer, Conor McGregor, said, stay ready so you don't have to get ready. In many respects, that is true in an operation, but also true with your patient leaving theatre and going to the ward. Your state of Zanshin is still there. And I certainly felt that looking after patients. So the character and the mindset and the parallels with Samurai Warrior, I believe, are very powerful. And they resonate with my thinking and the way I approach practice and the way I approach teaching and the way I approach patients. But what about movement? Because that's the cognitive side, but that's all part of the movement, and the cognitive side is all part of drawing the sword. Is being aware of what is around you and imagining the enemy. But the important part of the idea, and the most difficult part, is actually you're fighting yourself. And you have to project yourself in front of you and use that as an image to execute the cuts and the movements. So there are actually many traits of mindset and character that set us apart from chimpanzees and bonobos, our closest relatives. Our ability to think, create, because of our big brains. But we've got an upright posture. We have opposable thumbs and largely hairless bodies. It remains uncertain when we sort of developed from apes, but the oldest known species was actually found in Chad and dates back 7 million years ago. And this could be the first separation of apes and humans. They examined the skull and the brain and the size and facial features were that of a chimp, but the dentition was more of a human. But the most interesting part of the skull is that the foramen magnum, where the spinal cord goes into the skull, had actually migrated from being the back of something would be a quadruped to more underneath, suggesting that this particular species was standing on 2 legs. And this was Sahelanthropus chadensis, first unearthed in Chad in Central Africa in 2001. And researchers called this skeleton Tumai. In the local Goran language, Tumai means hope of life. A name often given to the babies born in that area because of the vast, dry, windy Durab Desert in northern Chad, where the fossil was found. So the interesting thing about this, because the foramen magnum was underneath, they suggest that this was the first ape that stood on its legs and walked with 2 legs. And being able to stand on 2 legs meant that you can look up above the savannah and spot your enemy around you. And they learned to walk. What's interesting actually in the Ido and in martial arts, and John Taylor, who's a 5th Dan karate sensei and trauma surgeon in Liverpool, says we have to learn to walk properly. And what I found in Ido is that my weight transfer was actually on my front foot and not on my back foot. So I have to learn to actually propel myself with the back foot and maintain my weight over the back foot before the transfer, and thereby centralize the gravity. It's amazing that nobody's pointed out this before, but it does mean that the movement is smoother, and it means that the draw is more precise and you're more upright. But what this has done, being able to move on two legs, has had enormous benefit. It means that the upper limbs are now able to explore the environment in a totally different way. So we fast forward millions of years and suddenly look at our upper limb as the reason we have been able to create, paint, build, operate, because we are standing upright. But standing upright means that it's a perpendicular line from the top through the ear, the shoulder, the elbow, the hip, just behind the knees to the ankles. And when standing upright, problem is with many people with mobile phones at the moment are walking around like this. And a lot of people are ending up with a curve in the neck. But standing upright is important, but also standing upright at the table. Don't lock your knees out. Keep your knees slightly flexed. That enables you to move the weight seamlessly from one side to another and keep the necessary muscle pump moving for long hours at the table. You'll find if you stand at the table and lock your knees out, then you've got a problem, particularly when you're starting to lean over. And as you're starting to lean over, you've got anterior pelvic tilt, you're pulling on your hamstrings, your shoulders fall forward, the hand forward, the chin starts coming from the midline, and when that happens, for every 2 centimeters, you're adding 2 kilograms. So, in theory, your chin could be 8 centimeters up from the midline. And in the end, you're supporting something like 26 kilograms of weight on your neck. And you can wonder then why you feel so tired at the end of the day. 92% of surgeons will end up with musculoskeletal degeneration over their lifetime. And it's only recently becoming recognized that we should attend to the posture and attend to fatigue. And it is, in many respects, a sport insofar as that you need to be fit. You need to have core, and you need to be able to flex and stretch every day to avoid that musculoskeletal problem. But the crazy thing is that we don't teach it and we don't practice it. We did a study looking at basic surgical skills across the globe and gathered 109 photographs. 102 of them were actually sitting down. Sitting down. The only surgeons that sit down are microsurgeons, hand surgeons, urogynecological surgeons. Everybody else stands. What's interesting, Prof. Ironman, who's the sensei here, a neurosurgeon, said we also need to, and we will talk about, posture using robots, laparoscopic skills, and microsurgery, and microscopes. But it is a serious problem, and it's something that is not taught. What we know that even after 4 to 3 hours with electromyography studies, you can evidence serious fatigue in the muscles of posture. Splenius capitis, upper trapezius, and erector spinae. And you wonder why, at the end of the week, you're feeling very tired. So strength training and stretching exercises do reduce pains. And you do need to have, and I recommend that if you've got any problems, that you seek physio or a proper coach before embarking in some of these exercises. So when we're looking then of the way the upper limb works, bear with me for a moment and just put your arms out and keep them out. Now, as soon as you put your arms out to the side, what happens is that the scapula moves around the chest wall. and it's fixed. But in that position, you've got 17 muscles that either insert, 6 of them, or originate from the scapula, 11 of them. And I'm sure you'll find as you stand that you're now becoming increasingly tired. That is not a functional way to use the hand at all. You can't walk around doing that. You're very limited in your movement. And as soon as you abduct your arm or flex it, you're increasing the major muscle work of the upper limb. And over a period of time, if you're holding that, you will have tremor. But it may be necessary on occasions. But in essence, the best place to actually stand, you can put your arms down now. It feels better, doesn't it? And your elbows are by your side and your shoulders are down. Now, what's interesting, as I'm holding my katana here, it needs to be in the midline at the level of my umbilicus, such that my hands, without moving my elbows, can actually reach for the sword and disengage it and draw it without moving my arm or moving my shoulders. And indeed, my sensei is so good at it, he turns his back to you and said, "Tell me when my sword is drawn." And you look and you look and you don't see any movement, and he turns around and his sword is in your face. But what the principle is that the shoulders are down, your elbows are by the side, and your hands literally can lift up. And there's a lot of movement that can be attained without moving the shoulder or the elbow from the side. And it's interesting, that is that position. And it's in this position one is effectively this functional anatomy. And that is why the countertops are the height they are. Okay? Such that your hands are palmar flexed, the elbow is slightly extended, and they're down. But actually, in this position, what you've done is isolated the intrinsic muscles of the hand. And this is important. Firstly, to demonstrate what are the biggest muscles in the forearm: flexor digitorum profundus, flexor pollicis longus. Do that, they grip. And those muscles are used by Tom Cruise to hang off helicopters. But when holding the sword, you walk around with your flexus pollicis longus flexing the distal interphalangeal joint, and no matter how hard you pull, you will not be able to pull my sword from the scalpel. Those are not the muscles that we should be using in surgery. That is a lot of force, and you can demonstrate that by pinching yourself. Go on, pinch yourself. That is sore, very sore, because you're generating, for a woman, 25 newtons, and for a man, 30 newtons. But now try and pinch yourself by keeping the distal interphalangeal joint extended. You can't pinch yourself that hard. So I think, in a way, the anatomy of the upper limb, and for a surgeon, should, and your function, the way you stand and the height of the table, should isolate the intrinsic muscles of the hand. So we talked about the grip and the opposition of the thumb. Imagine you're putting some salt on your food. That movement, that opponent's pollicis and the lumbricals extending the DIP joints, bring the palps of your fingers together. You've got more sensory input from the palps of your fingers to your brain than you actually have from the eye. And it's that movement. And that grip, which is the most sophisticated grip of all the hominids, and that is what makes you human. And that came through evolution because you're able to stand. But if you're not standing properly and not paying attention to that, you are not going to deliver the artistry and the finesse that we see all around us and what is necessary in an operation. And you therefore then have to start deconstructing how the upper limb moves. If it comes out to the side, up and forward, or back, you're putting a lot of extra weight in it. We need to use these muscles. So it then comes down to this concept of rotation, because next week we're going to go further onto the needles and we're going to talk about rotation and intrinsic muscle and show you how I think needle holders should be held. Because rotation happens at the glenohumeral joint. There you go. I can draw a circle around the logo because of flexion, extension, external rotation, all combined in the shallow glenohumeral cavity to enable you to rotate the upper arm. The rest, however, flexion, extension, adduction, adduction, put together, that's circumduction. That's not rotation. So where else in the upper limb do you actually get rotation? I'm just going to put this down for a moment. Get some weight. The rotation, if we actually look at the skeleton and then look at the head of the radius, and there's the head of the radius, it's round. So what actually happens, and what's beautiful about the design of the upper limb, is that the upper limb and the forearm and the elbow are there to place your hand in the right position. Okay? So that you can effect the work. And the hand rotates, or the radius rotates, or folds over the ulna, so you can supinate and pronate. Supinate and pronate. And that action is along that line of axis between the index finger, the middle finger, and the common flexor origin. And it folds over. This then puts your hand in the position and enables you to work with your fingers. And what we need to do, therefore, is use our gift of being able to feel our grains of salt between our thumb and our fingers, and this complex gift, to apply the maximum surface area of the pulps of our fingers with all our surgical instrument so you can feel them. So feeling is not blanching of the fingernail, you can see it blanching there. That's pressure. Feeling, you shouldn't see any blanching whatsoever. And I can see that through this gloves. Feeling is literally holding a needle holder in the palm of your hand. And this is why we recommend palming, because it is lying between the index finger and middle finger, the common flexor origin, and I can rotate. Imagine you're using a screwdriver, rotating, okay? Simple as that. That movement and that lightness of touch, because of the design and the anatomy of the upper limb, can be done at all sorts of angles. without impediment. Whereas if you put your fingers through, you are naturally getting a degree of circumduction and rotation. And rotation does not happen at the wrist. That is sort of scooping. So how does this work? Well, look at the end of this needle holder. I am pronating and I'm supinating. And I've got about 270 degrees. Pronating, supinating. Whereas if I got my fingers through, pronating, maybe 180 as compared to 250 degrees, but the end of the needle holder is going round as well. How do we actually, therefore, control the locking and unlocking, and what exercises can you do to practice? So I'm going to just take you over to this table and just demonstrate a few things for you. So I am holding palm, the needle holder, palpal finger, palpal finger, palpal finger, palpal finger, palpal finger, all gently applied to the instrument. I can lift it out, put it in, lift it out, put it in. I can put it down, pick it up. I don't have to engage and disengage my fingers as I pick this up. So the secret is the movement is the rotation of pronation, supination. But how do you unlock it? Well, the ratchet is only, and we'll focus down. If you look at the ratchet, that ratchet is only 1.5, 2 millimeters. So to unlock it does not require much movement at all. In fact, it's intrinsic movement of the hand. Position the ring over the metacarpal phalangeal joint of the thumb. That's where the maximum movement is going to happen. And you can work it out. If you lift my thumb up, I can push it away. That's a gross movement, but in doing that, I've unlocked just lifting my thumb up. So Shivani was with me the other day and said she had much smaller hands and couldn't do it. And we placed it, the needle holder in her hand, positioned the ring over the metacarpal phalangeal joint, and to unlock, simply said, lift your thumb up. And that was enough movement to unlock the ratchet. Now, to complete the rotation of a needle, the problem is that many people, when stitching, particularly with their fingers through, take the needle through the tissues, then unlock it and deliver it out. But the unlocking movement itself results in an inadvertent dropping of the arm and damage to the tissue. So it's best to unlock before the needle actually goes anywhere near the tissues. And a simple way of doing that, if I'm holding my needle holder like that, is practice doing it with your arm resting on a table or on a pillow. So there's no extra movement. And as I pronate, I've unlocked. And practice it yourself. Position it properly. Note that I'm not gripping. There's no blanching of my fingernails. As I pronate, I've unlocked. And now I can continue my supination to deliver the needle. But having unlocked it, I haven't put the ratchet back on. I can still hold and control the needle without the ratchet on. Okay? So I can still hold and control the needle. but all the movement and all the control is within the intrinsic muscles of the hand. Let's do that again. So I'm going to rotate it around, pronate, and I've unlocked. The way to practice it is position it properly, and it shouldn't take any more than the slightest of movement. There's no forearm movement involved whatsoever. And therefore the end remains controlled. I can also do this practicing with a bit of blue tack. Can I actually practice taking my needle around, focus on the point? So lock, unlock, but I don't want to see this being pushed in. And you're learning in this circumstance to control your rotation. You can see if you're pushing hard because the blue tack is actually indenting. And while you're learning to lock and unlock, simply putting a target on a bookend, putting your forceps on there, and practicing rotating and locking and unlocking so you get a nice smooth movement. Once you've got that and you're practiced locking and unlocking without dropping the forceps, dropping the needle holder, then you can progress to bringing your elbow up in the air. And can you do it in control without actually indenting the blue tack? Okay, so rotating around, I'm practicing, and I don't want to be pushing it in and creating holes. And this is a simple exercise to learn to control the rotation and remove the inadvertent dropping of the hand that I've often seen when people unlock the needle holder. So what we've gone through this evening and what we're talking about is how we have evolved to walking upright, to using our upper limbs. But what I'm trying to impart on you is that the understanding of the anatomy of the upper limb and understanding the functional height is important. And what's become synonymous with the Black Belt Academy and the table that you have that goes up and down at home is the ironing board. You would not iron up there, nor would you iron down there. You would find a comfortable height there. Funny, it's much the same position as my sword in the center line, and I could iron at that level. So the ironing board is very useful for practicing at home. And with all practice, it is absolutely important to ensure that all the ergonomics are correct. And you can do this yourself. When I was training, Chris Lincoln actually asked Sister, could you give me a bandage, please? A sterile bandage and a drip stand. And everybody looked at him. He's rather an eccentric gentleman. And he took a sterile bandage and he bandaged me to a drip stand. He said, there, now you're going to stand up straight. Never forgotten that. But an important lesson as we think about practicing our skills and learning skills as well. And with that, I'd actually like to ask my fellow senseis, Chris Caddy and Sile, and I'm not sure if Shree's with us, to join and discuss the mind movement as we've presented this evening for the Black Belt Academy. Sensei Kelly.
Good evening, David. Once again, masterclass. I particularly like the way that you approach the way that you lock and unlock the needle holder. Because what you're doing is you're dissociating the needle holder from your hand and getting people to realize how they lock and unlock it. Most people immediately stick their thumb and their ring finger through the rings and think that that's how they have to do it. So this is the reason for using good instruments. There's an old adage that a bad workman blames his tools, and that's why it's really important for us to use high quality tools when we're learning a trade and learning a skill.
Indeed. And that's why at the Black Belt Academy, we actually have, as part of that, our own instruments. And I spent a lot of time sourcing these instruments because it's important that they feel good and they got to help us. I agree, surgeons should never blame the tools, but I think in this case we justified in doing so because you need to be able to feel the instrument.
Indeed. And once again, it comes back to mindset. It's about setting yourself up for success. And at the beginning of every operation, you need to pause, breathe in, breathe out, and set yourself up with the right mindset. And similarly, you're talking about posture, the way that you stand, and it's about setting yourself up so you get your body right, your mind right, and then you can proceed with the operation. What more?
Well, what more? Yes, I wish it was that simple, but yes, those are the foundations. And what we're trying to impart with the Black Belt Academy is only when you have solid foundations can you actually understand the basics, can you delve deeper and practice the art and build on that and build the movements. And that is where, as Prof. Solaire said in the document, hello, young man, there's a future surgeon for you, where we can actually learn and practice the arts. So the proper standing position and functional anatomy of the upper limb really has to be acknowledged by all parties. But separating the upper limb is there, and the muscles of the upper limb are there to put your hands in the right place to do the job. The operating is with your hands. When you think about it, a pianist is playing with their hands. The upper limbs are just putting the hands in the right place. But they also sit down at the right height and then can play the piano. Surgery is the same. The dexterity and the finesse is with the hands. The humerus and the lower arm are there to put the hand in the right position. Sometimes the elbow has to go up, and we'll be talking about that when we're looking at the needle angles. On the needle angles, as I was standing there, this line between the horizontal and my forearm. We'll come back to that. Remember that angle, because that's going to be important as we look at the anatomy of the needle and how to mount the needle and how you can learn and practice to get the needle to work for you. Prof. Seeley was with us earlier on. Any comments, Prof?
Hello, Prof.
Nice to see you.
Hello, Prof. Can you hear me?
Yes, thank you.
Thank you very much. I missed the last Monday session. I thought it was canceled, so then I'm sorry for that. Yeah.
Well, last Monday was Deeper Valley. It was.
Yeah. All right.
It
Yeah.
was cancelled.
Sure. All right. Okay. I think I want to start with the mindset.
Mm-hmm.
Yes. Yeah. Because either a physician or a surgeon, then when we treat our patients and our aim is to get them healed, heal well. So this is the very first intention. So like when physicians want to prescribe any medications or treatment or procedures, and then this like thinking about the healing, how can we do the best? So same like a surgeon, when we want to perform a surgery, and then like pre-operative assessment and like all the histories and physical examinations and all the imaging and all the blood tests and gather everything, and then later on we decide what should be the best options for this best options of the surgery for this patient. Yeah. So it's like we set our mind and we make a shared decision making with our patients and counsels. And of course, like if we do abdominal surgery, it is magic box. So it's like we plan for something else, touch wood, like things can happen in other ways as well, so that we have to counsel them and document them in ahead what would be the possible consequences, particularly like 2-3 previous scars and all that. And then on the day of the surgery, and what I did learn from my mentor, Professor Sievers, again and again, he's my best teacher and really inspirational. So he demonstrated himself that he always be in a theater before patients sleep. We never start, okay, you open up and then I will come in a few minutes time. It's not that way that he practiced. He did it. So it's like he inspired me. I'm doing the same thing. So being as a surgeon, before patients sleep, before patient being put in anesthesia by anesthetist, and then greet the patient that, of course, we have done it pre-operative assessment on admission, but on the day itself, on the operation room, OT room, then greet the patient. Can you sleep well last night, for example? So it's like when patients see the surgeon, and then patients feel very comfortable and very confident, oh, my doctor is here. Rather
Indeed.
than, yes, he might or she might think that, oh, when I sleep, I never see my doctor. Where is my doctor? Whether he's stuck in a jam or whether my doctor is sick and whether can come or not, she might think that. So like greet the patient, then make sure that, and she's feel very, sometimes like I hold her hand, just a glimpse of, or a touch to her hand. So it's like she feel very safe and okay, you sleep now. You are in a good hand. So all these things is very important.
Well, that's the politeness, courtesy, and benevolence of
Yes, Prof.
someone. And
Yeah.
that is putting it in practice. You don't just march in, do the operation, and march out. You have an overall responsibility,
Sure.
not only to the patient, but it's polite to be there on time, so nobody's waiting for you.
Yes, Prof. Yeah. And at the time of washing hand, this is what I've been practice, like I think any religious belief you can practice too, rather than we just chit chat about last night or, where do you went out and, it's like at the time of the washing hand, I think I always myself cool down and then do my prayer. I'm a Buddhist, so it's like I just a kind of pulling down myself with the prayer. I think the other,
But it was a bit like athletes, as we were saying, getting into the zone, or the mushi, establishing the zone and getting into that flow state.
yes,
As I've often said, likewise, when you're scrubbing up, it's part of that ritual to get
yes,
into that flow state.
the spiritual, ritual things,
There's a spiritual element. It is actually emptying your mind from distractions and worries and preoccupations as well.
Sure.
So you can totally focus on yourself, but
Yes,
actually
bro.
project that focus and zanshin on the patient.
Yes, yeah.
And these are elements of operating that you and I understand, but
Sure.
very few, certainly very few people during my training actually describe these elements more important. And that's why I
Yeah,
brought it up this evening as well. And you've eloquently, Sile, eloquently described that. And
sure.
on those attributes and the various sheens and characters part and parcel of being a surgeon.
Sure.
And it's Bushido means the way. And in many respects, it's the way of the surgeon as well.
Yeah. Then another important thing is that the surgery is not a one lady show or one man show. It's a team. All right, anesthetist team, then scrub team, and then also the assistant, and then also the runner, then who pass the instrument, who go and get the necessary instrument and drugs and all that. We call it runner as well. So after I scrub, I gown it, and then the first thing I ask the team, how are you, my assistant? How are you today? Have you had your breakfast or not? Because today will be a long surgery, like war times and like 4 or 5 hours of surgery. So you have a, whether good breakfast or not, something like that. So it's like we always want our environment to be a very pleasant environment, working environment. Yeah. So appreciate their work.
That's almost extending the issue and clear understanding of yourself and purpose and involving the whole team. And
Sure.
it's a lovely subject to bring up because briefing and debriefing is not a checklist.
No.
It's called the who checklist. And I think the operative word is who. Who is on the table and who are you working with? Do you know their
Yeah,
name?
sure.
So in our briefing sessions, we'd go around and ask, any celebrations today? Anybody troubled by anything? Anybody
Sure.
want to share any news? On one
Sure.
occasion, I asked anybody troubled by anything, and an ODP followed me out of theatre and said, actually, I'm at a tribunal this afternoon, I might lose my job.
Sure.
You just think to yourself, hang on a sec, I'm about to do major heart surgery with a chap in theatre who's clearly going to be distracted.
Yeah. The regarding the posture and then the table height, and I myself put it in the waistline, the area. Yeah. But I always ask my assistant, are you okay with that height?
Thank you
Yeah.
for that as well.
Yeah, right.
Because
So it's like it's
both of you
important for
have to
them
be
also.
comfortable with that height.
Sure.
And if there's a disparity in height, one of you has to be on a step.
Sure. Yeah.
And
So I
so,
always ask for the platform if
yes,
my assistant is tall. Yeah.
yes.
You
So
have to respect.
exactly. So you asked for a platform, and I did the same with Michael. He was 6'5", 6'6", and I was the first consultant ever to stand on a platform. So when assisting me, he was at a comfortable height. Until that time, nobody had bothered. And it's a shared height because you can't stand at the table
Sure.
as well. So that's an excellent point, Sydney. Very good. Thank you.
Yeah. And the last point is that once the surgery is over, especially like cesarean section, the patient is awake and under spinal anesthesia. And I just say thank you to the anesthetist. And then, so like I introduce, I let my patients to appreciate the anesthetist and the other teams members, their effort. So it's like the patient also like appreciate the other team members. It's not only me, this as a pilot or a main person, a captain, leading this team. Then I also let my patients to appreciate, not only myself appreciate my team, and then also let the patients to appreciate my team members as well. So they all very happy and very pleasant environment.
Sile, that's exactly why you're a sensei with the Black Belt Academy, because you practice the way of the surgeon, everything we've described. And those are elements that need to be role modeled, but I also think now we need to make them explicit as we are. And next time you in theatre and training, have a look around and look at the way the surgeon is demonstrating their sheen and codes of conduct around theatre. Are they behaving like a samurai? We hope so.
Sure, Prof. Yeah. Most importantly, in case of emergency, it just happened, we should not be panic.
Exactly.
And yeah, this is what Prof. Chris mentioned. If anything crisis, just breathe in and out, and you focus again that what
Exactly.
we should be done the best for the patient to save the patient's life.
And that's also part of the practice in martial arts. And another one of the sheens. Totally mind like water. Totally unperturbed. As Professor Samagda Yakub said, cardiac surgeons do not jump.
Thank you very much, Prof.
Thank you very much, Sile, for your insights. Extremely valuable as usual. And thank you to Sensei Caddy. Nice to see his grandson there. Hopefully he'll be a surgeon in the future. I hope this has made sense to you. I want you to actually have a look at that photograph we've put up and look at the way we are training our surgeons of today. And perhaps you can actually put on the form everything you can see. Yes, they're sitting down. Look at their elbows. Look at that way they're holding the instruments. And these are surgical skills counts. But when you look at it, we appear to be ignoring a lot of basic things. Sensei Caddy, closing words from you.
Yeah, I think as a surgeon, what we're trying to do is to learn to be comfortable being uncomfortable. So when you're in a crisis or emergency situation, lots of things going on, but you need to learn to be comfortable in that situation. It's about stilling your mind and being completely in control of what's happening.
Indeed.
So once again, thank you for your words of wisdom, and thank you, Sile, for joining us.
And we wish everyone well. And I'd like to thank Aisha for on production this evening. Wonderful. We look forward to seeing you next week. And please pass the word round. Be well and stay safe. Thank you.
Thank you, Professor Devi. Thank you very much. It was a lovely session.